All right, good morning, everyone. It's my pleasure to introduce our seminar speaker today. Dr. Pamela Hull is professor of behavioral science and the William Stamps Farish Endowed Chair in Cancer Research at the University of Kentucky. She also serves as the associate director for population science and community impact at the UK Markey Cancer Center. She's trained as a sociologist with a BA from Duke University and master's and PhD from Vanderbilt University. She started her faculty career at Vanderbilt University before she moved to UK in 2020. Her research is focused on implementation science and community engaged approaches for cancer prevention and survivorship research, and also is focused highly on reducing cancer disparities. Her current focus is on evidence-based practices for cancer prevention and control, including HPV vaccination and obesity prevention. Her work's been supported by multiple NIH R and U grants, and also by grants from the CDC, USDA, and industry. Her group at UK Markey Cancer Center is also a national leader in community outreach and engagement for national NCI designated cancer centers. One of the main contributions they've made in recent years is the development of the Cancer in Focus tool, which we and other cancer centers have used to improve our catchment analysis for our cancer center. Today, she's going to talk about two projects that she's working on focused on tobacco and cancer survivorship using community engaged approaches. Dr. Hull.
That's impressive. I should get you to write my bio. Hi, good morning, everybody. And I know we've got an audience online too. I don't know if they can see, I guess. So it's a pleasure to be here again. I'm part of the External Advisory Board, so it's always great to come back and visit in a more casual setting. So I decided to talk today about some of the research I'm involved in where we're using some different community engagement approaches. And so I'm not going to be talking about our community outreach and engagement program of the Cancer Center, but instead like things that I work on is research. So one is, I'm actually an MPI on the project, the cancer survivorship related one that I co-lead. And then the other one, I lead an outreach core for a U54 grant that I'll talk about what we've done through that for that core for that project. So I call it community co-design because there's kind of we're working in community and one is design intervention and one is design community outreach and recruitment and advertising strategies. My disclosures, speaking in my own opinions. First, I wanted to give you a little introduction to Kentucky. If you don't know already, there's some things we're famous for. We have 450 horse farms in Kentucky. Lexington is the horse capital of the world. And we are also famous for our bourbon distilleries. If you ever want to come do the bourbon trail and sample lots of yummy bourbon. And we really, really, really love basketball, although it hasn't been going so great the past few years, but hopefully we hope with our new coach, it'll start to get better again. But then I also love two things about Kentucky is our Appalachian Mountains and also bluegrass music, like old school bluegrass. So lots of beautiful things to be proud of in Kentucky. And I wanted to say that first because then I'm going to tell you about some of our problems. So I always kind of try to start with the positive. So I'm going to talk first about the Comprehensive Connected Cancer Care Program, which we call C4 for short. And I co-lead that with Dr. Mullet and Dr. Chi at UK. Dr. Mullet is a thoracic surgeon and Dr. Chi is a health service engineer. So talking about our challenges in the state of Kentucky, our catchment area that the Cancer Center serves is the whole entire state of Kentucky. We're the only NCI designated cancer in this center in the state. And our population is about 4.5 million people. So it's not a huge population, but we're quite spread out. And a large percentage is in rural counties. About 40%, almost 40% of the population lives in rural counties. So that's a lot larger than the US. We have a little bit less racial and ethnic diversity than the US as a whole, but in our urban areas, we do have more diversity. Some of the challenges we have are basically low socioeconomic status challenges, particularly in the rural areas and especially in Appalachian Kentucky, which is mostly rural, 85% rural. So we have lower levels of education, higher levels of poverty in those areas. And part of that's compounded then by people leaving the area because of lack of jobs and then that's kind of a cycle. But one of our positives that I highlighted in green there is we have a low rate of uninsured for the state because we have Medicaid expansion, which has been very helpful for our population, and a large percentage of the population is on Medicaid in the state. But note in the eastern half of the state, that's where the Appalachian region is. So I'll be talking some about that state, or that part of the state. So we also have a big cluster of persistent poverty counties in eastern Kentucky and the Appalachian area. And that's, if you're not familiar, counties that have had basically high rates of poverty over multiple decades. So, it's pretty challenging to change that. And we have several challenges in terms of health behaviors, high rates of smoking and obesity, and high rates of cancer. We do have the #1 highest overall cancer incidence and overall cancer mortality in the country. For 1 year, we actually moved down to #2 for mortality. We got excited, but now we're back up in 1. So it is a challenge, and several cancers were either #1 or top 5, lung cancer being one, were #1 for incidence and mortality, unfortunately, and higher in the Appalachian areas for most of those cancers. Also, something that this group, when I moved to UK in 2020, and the group that I'm working with in this project started working on the foundation of this project back in 2017, working with NCI on kind of looking at the dual problem of high cancer burden and socioeconomic challenges with also low access to broadband connectivity at the time. Things have improved somewhat, but there's still challenges geographically, and somehow the dot moved down. It is over Tennessee now instead of Kentucky. So I didn't see that when I was. Oh, really? Oh, I stopped sharing for a second to fix the dot. So I think I messed it up. I just need to go on slideshow again. Sorry, I broke it.
And then your PowerPoint. Yeah, you dropped out of PowerPoint.
Sorry, I was just
No
trying
worries.
to fix the map.
Oh.
So,
Oh, all right.
Thanks. So especially in the mountainous areas, even if you have 5G service available, it might not get to your valley, your holler, what we call hollers. Or if it's available in the area, you might not be able to afford paying for it, or it might not come all the way to your house. So they worked on sort of getting groups of stakeholders together to think about what should we do about this problem. We have all these challenges with cancer. There are opportunities with internet, with telehealth and things like that that could overcome some of the geographic challenges, but that doesn't benefit people if they don't have access to it. And then, how should we leverage technology to help these challenges? And so they got together lots of different stakeholders, patients and caregivers, and oncology providers, nurses, social workers, community organizations, and they designed this process building on human-centered design processes and also general community engagement approaches. They built this community co-design framework for applying sort of technology applications in the area of cancer. So they went through these various steps of sort of coming together, identifying what the challenges were, but like the data I just showed. They did some ethnographic work, a lot of qualitative work, thinking about culture and context and people's understanding and desires and priorities, got together to define the problem and start brainstorming and co-designing what are some solutions, what should we do, and then went through some various iterative refining and development cycles together. This is just some pictures from some of the early co-design studios that they did together, and some of the ideas that came out of it were that people thought there needed to be more awareness for sort of the challenges of cancer and the opportunities for prevention and treatment, more navigation of the resources and communication resources for cancer care. So the kind of solution that they came up with was to develop a mobile app for patients called My Path, and a model for delivering this service to track people's psychosocial distress, as well as coordination of care and helping to overcome those challenges. So this is the first prototype that they developed called My Path, kind of just a simple prototype. We did some pilot testing with it and got some positive feedback on it for usability and things. And so when I got there, they were ready to sort of move on to the next phase. And my counterpart, Dr. Robin Vanderpool, moved on to NCI. So I sort of took her role on the team and helped with the community engagement pieces of it. So we kind of started to focus on specifically the social needs aspects of the issues that the groups had come up with and how we could address that with both the digital technology tools and also strengthening what we do for patient navigation overall. And it was helpful. What really came out of the groups is that people think about their wellness as a whole. They don't just think about their cancer here and other things here. Like it's the whole body wellness and their whole health. So helping both providers understand as well and patients that your mental health, emotional health is just as important as your cancer and your other physical conditions as well, and that we should be thinking about that in your context of healthcare as well, because if you can't get over social challenges, that can get away of your care for your cancer. And so some of the terms we kind of throw around often interchangeably, social determinants of health we use a lot, and social needs. I like this continuum. It kind of helps you see that there's sort of a multi-level approach there where social determinants of health are broad, sort of society level that affects people's in communities and how it shapes how our society plays out and how resources distribute and things like that. Then social risks is more of you live in a community where this social risk exists and it could affect you. It may or may not affect you. And then down to the individual level, do you specifically have social needs? So if we use, say, zip code data on area deprivation index, for example, that would be a social risk. It's a community level characteristic that you're at risk of having that type of issue, where social needs, when you ask the individual, do you need help with transportation or things like that? And so that's where we focus on then in this context of patients coming in for their cancer care and seeing what needs they have and how they can be assisted in that moment. It's also great to have other studies that look at the society level and sort of addressing the root causes of the social determinants of health, but this specifically is looking more at the individual level and what can you do in that moment to help make sure people get the care that they need and that these non-medical issues don't get in the way of their care. So that's including things like financial resources or difficulties paying bills, housing instability, lodging for our population is a big thing because people come from rural areas and they just need a temporary place to stay while they're having their treatment. Transportation, all sorts of transportation issues, the biggest one really for our population, food insecurity in general, and other non-medical things that can get in the way of care. So as our project evolved and we put together sort of a next phase proposal, and we got funded with Merck Foundation, a funding opportunity called Alliance for Equity in Cancer Care. And there's 8 grantees around the country that we work together and coordinate monthly across grantees as well. But our goal was to enhance the ability of our cancer program and other cancer programs to be able to meet the social needs of cancer patients through 2 tools, some new digital tools to help enhance the work that is already going on. And most cancer centers have some sort of staff, social workers or nurse navigators or patient navigators, and plus some additional patient navigator support. So it's not digital tools by themselves. They are meant to enhance what the staff can do. Patients want to talk to people, not just have an app. And then the long-term goal is to advance health equity overall by helping to remove these social need barriers so people have timely access to their cancer care. So we are able to align this work with 2 very important Commission on Cancer standards. I always, as I heard in the introduction, I'm all about evidence-based practices and implementing them in practice and doing what we can to improve how we implement them. So this is very helpful when we're talking to our clinicians and our operational leaders to point out that this paying attention to these strategies helps the cancer center meet these standards for the Commission on Cancer. They're required to do psychosocial distress screening. It's kind of minimal, it's only at least once required, but most cancer centers do more often. And then to address barriers to care in some way, again, that could be a little bit more robust standard, but at least it's calling out the need to address barriers to care. And we also found that it's important to sort of help educate all of the team members about navigation itself. There's lots of different kinds of navigation and different roles in navigation. And sometimes it gets confusing when they get all mixed together. And every place does it differently too. The way jobs and roles and responsibilities are split up is different at every cancer center. So we like this framework that that was published in JONS. I think it came from AONN, if I'm not mistaken, the Association of Oncology Nurse Navigators and Patient Navigators. But they call out the the professional roles as nurse navigators, social work navigators, and non-clinical patient navigators. Those could be community health workers or other staff that are just not clinical staff, not clinically trained. And so the key is sort of thinking the same way that advanced practice nurses can support physicians and say licensed practical nurses can help support RNs. So everyone can work at the top of their license, but also have the unique things that they contribute. So nurse navigators often address all the physical health and social needs with patients, but their primary focus is the physical health and coordinating care. And then the social work navigators are trained to do the more advanced complex needs and mental health and emotional needs as well, but they also do the practical needs, whereas your non-clinical patient navigators are not trained to do those clinical things, but they can help in those practical needs, the social needs. So it's helpful to have all of them, a mix of them, because you have patients with all different levels of needs, and we usually don't have enough staff to cover all of them. So we found, and as we've worked with other centers who are funded through this mechanism as well, it's very important to coordinate workflows across different navigator roles and who's going to do what and how you coordinate across them to really maximize efficiency and cost effectiveness and the best experience for patients. So for our C4 intervention, there are three main components. One is a mobile app for the patient, and the second is a navigation dashboard for the patient navigators and social workers. And then third, over on the right, is also some training modules and that go along with helping understand social needs and navigation and what those things are for. So the app is really to help identify, focusing on the social needs and somewhat emotional health needs, the things that the social workers and patient navigators can help with. And when things come up in terms of the physical need area, it's a matter of connecting them to their cancer care team, directing them to communicate via MyChart, sending a message to the nurse and things like that, so they can connect with them and follow up with those things. It's not meant to duplicate that communication or needs. But what the patient does is they fill out a psychosocial distress screener, an assessment. We'll talk about that in a second. And then based on their answers, it gives them resources in their local area that can address those needs, some services that are available that they may be interested in using, and then helps them sort of keep track of it, reminding them later, did you get what you need? Do you need help? And then facilitating connections with the patient navigator. So whenever they need help, the patient navigator can step in and give them some help. And then the dashboard is helpful for the navigator and social workers to be able to track all of their patients across all of them at once. It's often hard to do that in Epic or other EHRs. So we're eventually looking towards integrating more with Epic, but right now so far it's a standalone dashboard, but that the future state will be more integrated within EHR. So we're doing this project at Markey Cancer Center, UK Markey Cancer. That's sort of in the middle right where you see the star in the lighter block there. And then the three text boxes, you'll see the pointing to three of our affiliate network sites. We have a network of 20 community-based oncology programs across the state. They're not operated by UK Healthcare, they're other health systems. And so one, ARH is Appalachian Regional Healthcare, that's located in Hazard, Kentucky, in the heart of Appalachia. And then St. Elizabeth Healthcare is in Northern Kentucky, which is the suburbs of Cincinnati. And then Med Center Health Bowling Green is on the western side, and that is sort of between Lexington and Nashville, roughly. So all serve a mix of rural, it's some rural populations to some extent. So, yeah.
For those other sites, how did those work?
Yeah.
You said they're not part of 2K.
Right. This net.
Can you repeat that question? We don't have mics in the room for the virtual.
Yeah, thank you. So I'll repeat the question. It was how did the partnerships evolve? How were we able to establish those partnerships with the other sites? The network started 20 years ago in 2006 to establish more partnerships with these oncology programs across the state. They help with them achieving and maintain their COC standards, accreditation and standards, and do continuing education support, and also facilitating referrals into Markey for specialized care, and then making sure they can get back home. The goal of the network is to improve the quality of care out in the community hospitals so people don't have to drive to Lexington to get good care, and they can stay closer to home and only come to Markey when they need to, and then go back to their provider. And then they also coordinate on clinical studies. So several of them can do therapeutic trials, but all of them can participate in observational studies and non-therapeutic interventions. So that was a network that's already been established, and we were able to there's a mechanisms for saying, okay, we have a project we want to collaborate on, develop a project together, or when there's one available, they kind of reach out to them and see who's interested in participating. So yeah, we can talk more about that too if you want. This is our team at Markey is our psych oncology services that we have 11 social workers, one non-clinical patient navigator that we're able to bring on through an ACS grant, as well as registered dietitians. I just want to give them a shout out because they're an awesome team. So in terms of how we've been working with our stakeholders in doing co-design together, we've done several different things. The first 3 are sort of data collection activities. Well, there are data collection activities, but similar to what they did a few years ago, we did another round of co-design studios. We did one at each of the 4 sites where we brought all together at one time, former patients, not actively in treatment, former patients, caregivers, clinicians, community organizations from the area, social workers, navigators, and operations or administrative staff. Basically all of those categories we tried to get to the table, and we had a good mix of them. So we did it as we brought each site online. It kind of was staggered out every 6 months to a year. So it was nice as we got through different phases of the project, and they were able to give input on where we are in each stage of the development. So we had like a 2-hour session where they actively got to give input and share ideas and think through things and how things would work and what they want, both from the patient perspective and the operational perspective. And then as we've been designing and doing the iterative process of development with the app, we've been doing usability interviews with individual patients as we go along. And then we're doing an evaluation where we collected first a baseline sample at each site, which is essentially usual care time period. It's not simultaneously randomized arms. It's pseudo experimental. So we have a baseline time period first, and then another sample of patients in the implementation time period when they get the app. So as the sites have come on in a staggered way. So they do their baseline first and then they go to implementation. So you'll see the numbers are not balanced because they haven't all moved to implementation yet. But as we're doing that, we're getting feedback from every patient that's using the app, as there's troubleshooting issues we had to fix, or there's just feedback on what's confusing and what they'd like to see, and get feedback from them as they're using it. And then we have several other mechanisms to get ongoing feedback through more long-term partners. So we're not steady participants, they're partners in the research. And sort of a core group is our patient advocate committee, and that's organized through our research advocacy program that we have that includes former patients, caregivers, and community organizations from each of the 4 sites and the areas that they serve. And they've been involved through multiple meetings and giving input and helping to shape the app. And then we also have a patient advisory group at Markey that we've consulted with a couple of times as well. And then at each site, we established a clinical collaborator committee, because the clinicians and the social workers and navigators, operational leaders, they're all very key, important players to, we want to make sure we design something that is going to be useful, is going to help expand and enhance what they do, not be a burden. If it's not something that's going to be helpful and people aren't going to want to use, then it's not going to get used. So really trying to make it valuable, bring value to the work, and be something that would be sustainable because they want to use it. So they've been really giving really, really important input all along the way. So kind of get a little bit more into the nuts and bolts of how it works. So we use the NCC and distress thermometer tool. I don't know if you guys use that here. A lot of places do. This is the paper version. Our patients can do it on MyChart for those who use it. I think about 60% of our patients use MyChart. Then otherwise it can be done on paper, or sometimes they ask the questions. But in case you're not familiar, we sort of group them into 3 areas: the physical, mental, and social needs areas. And so the practical concerns is the main category section where the social needs are. There's also some over in the other areas as well. But that's mainly what we focus on in the app, and the other things we direct them to psych-oncology services to help get them connected with the other things that they need. So one thing we did was working with the internal teams is workflow analysis at each site of what's the current process look like, and where the pain points and where the things where these new digital tools could help. And so this is what we look at Marquee, first with the timing of screening, when it happens and how it happens. And so you can see on basically the EHR is set up to trigger if they're due for a screening or not. So we do every 45 days ish. So if they come in for an appointment and it's been 45 days or more since the last appointment, then they're due to do a screening. If it's been less than 45 days, then they're not. So it prompts them to do the screening. So the downside that we heard from the staff is that we don't know what happens in between the 45 days. So they come in for the appointment, we might hear about some needs, but then they go home and we don't know anything that's happening until they come back in. And so if they have a challenge come up while they're at home that could interfere with the next appointment, we might never know, and they might not show up for their appointment. And then sometimes the processes don't always go as they are ideally planned, and people get missed. Not everybody gets the screening done. And again, needs arise while people are at home. That came up a lot with the patients too. Like, I need things to get to my next appointment. And then we looked more in detail. You don't have to like read through all of this. Essentially, like, then what happens? Who looks at the results and what happens with them? And so because at Marquee, I think, and we've heard from the other sites as well, there's very limited staff available to meet these needs, either like social workers or nurse navigators or patient navigators. So the way we do it at Marquee is based on the distress score, the number value that the person chooses, their level of distress. They triage it based on that. So if it's a 9 or 10, really high distress, that's urgent, they go look for the person in their appointment. If it's a 7 or 8, then they call them the next day. And if it's 6 or below, they don't have the capacity to reach out to them actively. So if a patient hears about it, they can come, or if a nurse or other provider can refer them to psych-oncology, but otherwise they don't have the bandwidth, or didn't formally, to go out and meet those, and even look what the needs are. So when we're able to bring on that non-clinical navigator, he's able to look at the patients who are 6 and below and start seeing which ones have some problems that we could help with and really, start addressing. So that immediately helped expand capacity. But what we want then for the digital tools is to help meet the needs of those patients that are currently not being reached. So they might not have as emotional distress as an issue right now. They just need help with a ride or other, paying their bills. And so if the app can facilitate connecting them without so much work, staff time, then that hopefully, will help overcome some problems that aren't being addressed now. And then also the challenges like tracking and monitoring, and really what we call closed loop referrals. If you make a referral to a service, do you ever find out if they got the service or not? And currently, right now, they don't have a way to track that. If they happen to talk to a patient again, they'll note it in their notes, but that's about it. So it's another thing we tried to add with the app. And then monitoring outcomes. Like, really, a lot of navigation programs struggle with how to know if it's making impact. So if you need to make a business case to the cancer center, if we need more social workers, we need more navigators, you need to be able to show why and like how it's going to make an impact. Is it going to reduce no-show rates? Is it going to speed up time to treatment intervals? Is it going to reduce hospital readmissions? So those are the kind of outcomes we're trying to look at and, manage how to do that. So these are some screenshots from the app. This is, again, always still in flux. We're currently implementing some of these newer designs that we got feedback on. But just to quickly show you, first, a person can do a check-in at the bottom there. That is to do the stress thermometer questions. And at the end, one thing we added was, okay, you checked off these items, which ones do you actually want help with? That's something we got feedback on from the patients, like, well, I have trouble paying my bills. I don't need help right now. I have help from my family or something like that. And then that narrows down, the information gets pushed back to them. And then they can track which ones they are, sort of looked into, they've saved, or they're in process of getting the completed ones. And then we've made sort of a self-report mechanism to prompt and check in. Did you get that service? No. Are you having a problem? Do you need help with a navigator? What do you need? Or yes, did you get it? How was it? Were your needs met? So we can close the loop on those referrals and help them finish them.
Can I ask another
Yeah.
question? So is this integrated with Epic?
Not currently. Yeah.
Okay.
That's
It's a different dashboard.
It's separate right now. Yeah. That's a future goal.
Tell me a little bit about, you said the non-clinical map, how they then have the permission to access that.
Oh, okay. The questions. Yeah. The question was, is the app currently integrated with Epic and the distress screen that we do through Epic and MyChart? It is not currently. So that's what we're moving towards, that goal of at least minimally bringing in the ones integrating the whole process in terms of workflow, but we eventually having two-way sharing of information. Go ahead.
Yeah, and I think the second question was just about the privacy, so that people utilizing the app, then how they actually have access to that clinical data.
Yeah.
Because that is a challenge with our infrastructure right now, in that who actually can do that. The clinical team can obviously review things in Epic or distress screens. That would be very different than somebody who's coming in from the outside saying, I'm going to be a clinical health worker to help navigate, as you outlined, like the 6 and under distress.
Right. Well, that person is part of the psych oncology services team, in the whole team with the social workers. So they have access to all of the EHR and things like that when they have a patient that has needs, and they have a flow sheet in Epic where they document their encounters with patients. So they're part of the non-medical clinical team. Yeah, but we're working with our cancer research informatics shared resource, and they're the ones building the app and ensuring all the security protocols and things. And yes, that will be like an additional step. That's why we haven't done the EHR integration yet, because then you have to sort of do another layer of things for the PHI and the the HIPAA things, and making sure those connections are secure, and really legal and things are like, we're very picky about what we let come into Epic. So it's easier for us to pull from Epic, but to have it go back into Epic has to be sort of a process that we have to go through. Yeah. So, but getting all the feedback all along the way, we're hoping they'll make it easier when we're ready to get to that we know how the clinical and how the psych oncology team wants it to work, how they want it to integrate with the Epic screens and things like that. So hopefully that'll help. And I just want to acknowledge our team, and I'm going to go on to the other project. Any questions about this one before I move on? Okay. Well, we can keep talking about this later, but I'm going to hop onto the other one. So this is a little bit different, quite different actually. This is a project called Apple Trust, which stands for Appalachian Tobacco Regulatory Science Team. So I am not a tobacco researcher, but some of our colleagues at the Cancer Center are. This is led by Shanika Rose, Mickey Kafarnis, and Seth Himmelhoek. And they got this U54 grant a couple years ago. And it's a co-funded between NIH, either NIDA or NCI funded them from FDA. So the money comes through FDA essentially, mostly. So has to follow all these special rules that FDA has. So it was new to me to learn what tobacco regulatory science is. So I'll just give us a little preview for those of you who may not know. So it's not tobacco interventions. It's not preventing tobacco use. It's not interventions for cessation. It is specifically research that can answer the questions that FDA needs to know in order to regulate tobacco nicotine products. And they only actually fairly recently were empowered or got the authority to regulate these products, somewhat starting in 2009, cigarettes and a few tobacco products, then it was expanded in 2021. So all of the other nicotine products are under that umbrella as well. So basically, tobacco regulatory science looks at the potential regulations that FDA could implement in the future. And FDA lists out the specific things the specific areas, because they are charged to regulate things for the safety and the public health. So specifically, there's a list of, like I said, categories or policies, and these are the three that our team looks at. The research is relevant for non-combustible tobacco products that are more the novel products, like Zyn, the nicotine pouches you may have heard of, looking at lower nicotine level cigarettes as an option, and then flavored and menthol restrictions on cigarettes. So we are looking at the impact of rurality on tobacco behaviors and perceptions and purchasing patterns and marketing and things like that. So instead of just doing sort of rural versus urban, this county versus this county, we have a very wide diversity of types of rurality in very different rural communities across Appalachia. So we're looking at levels of rurality from more rural to less rural. So that's sort of one of the innovations that they brought to the grant. And why was it important to do this in Appalachian Kentucky? For one thing, we have really high tobacco use patterns. We're either, depending on the year, the number 2 or number 4 highest in tobacco use across the country. And like I said, we have the highest lung cancer incidence mortality, also high on other tobacco-related cancers. And as I mentioned, rural communities are, FDA officially mentioned on the RFA, rural communities call them out as a vulnerable population that needs to be focused on more for regulatory science, because in the past, it's largely not been included. I mean, there are very, very few, a handful of the studies that have been previously done included in these substantial rural populations. So this would be the first time an Appalachian rural population is included in the research funded through these mechanisms. So we have 3 projects under the grant. The project 1 is the main, it's a cohort study. And so it's divided into 2 samples, a combination of a probability sample, a random household sample, and a non-probability sample, which was community-based recruitment convenience sample. And so they're being enrolled gradually over time. We're actually almost done with that for the non-probability part. But they do a survey every 6 months, and some qualitative work. Interviews are also collected. But as I said, they look at tobacco use patterns, opinions, views about regulations, and things like that. And then from the non-probability sample, project 2 recruits from that sample. That is focused on young adults, 18 to 24 years old. And they're looking at the availability of different tobacco and nicotine products in stores. They do store audits. And then they also, so that's not with the study participants, that's directly from the staff. And then the study participants report real-time exposure to tobacco marketing through ecological momentary assessment surveys in their phone. And then they also do additional surveys about, so they look at sort of the correlation of exposure to marketing and changes in their use of tobacco nicotine products. And then project 3 is doing what's called an experimental tobacco marketplace. They basically have a hypothetical store as an online store, which I don't think you can currently, technically use to buy tobacco products, but it just gives a simulation, essentially, a simulation of buying scenarios, purchasing scenarios of if these are the different products you have available, which ones would you choose? And what are you currently using? Would you switch, and why? And depending on, they vary prices and things like that. So they're looking at switching behaviors, and this is with people who use tobacco or nicotine products and do not plan to quit, because they actually give them some low nicotine cigarettes to sample and see if they would use them or not. So we're doing the study in 2 clusters of counties in Appalachian Kentucky. The blue cluster up in the top right is the Kentucky side of the metro area of Huntington, West Virginia. It's an MSA area, and those 3 counties are part of that MSA. Although the more urban part is on the West Virginia side. Ashland is the sort of smaller city part on the Kentucky side. And then the green cluster is around Hazard, Kentucky, and the surrounding counties. Those are all classified as rural counties. So those bubbles give you a relative size of the population. So you can see they're definitely smaller populations, but we're looking at degrees of rurality, and this is based on, they do an index of relative rurality based on distance, of commuting into different commercial areas and population size and various factors. And just to give you a quick snapshot of the tobacco use patterns. So in the US, we have just in terms of smoking cigarettes, it's about 14% of adults that currently smoke. And in Kentucky overall, it's almost 24%. So it's quite a bit higher, but you can see across these counties, there's even higher. All of the counties are higher than the state rate as well. And some as high as 31%. So quite a lot of product use. So as I mentioned, I co-lead the Community Outreach and Participant Engagement Core for this project, and we call it COPE for short. So Outreach and Participant Engagement. So it's not outreach in terms of health education, it's more outreach of getting out into the community and getting them engaged with the study, either as participants or in other ways as well. So I summarize here sort of some of the key ingredients that we've been putting into our community engagement approach for this project. One is we built on our existing networks that we already had through our cancer centers community outreach and engagement program. We have a outreach program I'll show you that we've built on our partnerships. And then we formed a CAB, a community advisory board in each of those 2 catchment areas. And then we've worked together. The co-design part is working together with the community advisory board and our other partners in co-designing the outreach campaign and the messaging and the ways that we reach people in the community. And then we've hired field staff who live in those local areas, in those counties where the study is being conducted. So they live there, they know everybody, they're from the local community. It's very important in Appalachia there's much better reception if you're a local community member versus someone driving over to Lexington and coming, even though we have really good partnerships and great perception of UK as a partner, still outsiders are outsiders. So that's a very key part that's helped make the project successful. And plus we think is important because we're investing in the local economy. We're providing jobs in the communities as well. And then finally, the combining that personal interaction with the field staff is super important, but combining that then with advertising through multiple channels it's been very helpful, the combination of those 2. This is the outreach program I mentioned, Kentucky Cancer Program that we co-lead this University of Louisville. The map at the top, you'll see the Appalachian outline again. The eastern half is our University of Kentucky employees, and the western half is University of Louisville employees, and we coordinate this outreach program across the state. So each of those staff also lives in those districts. They're local community members who are from that area and live in those areas, and they have very well-established networks of partnerships across those counties, from health departments, faith-based organizations, nonprofits, government, businesses, all sorts of sectors. We pay the community advice. So 2 of our employees from the outreach program, and the ones that cover those areas, they are in charge of the community advisory boards. They form them and they facilitate the meetings and stay in communication with the community advisory boards. They have 3 meetings in Zoom, and 1 is our in-person annual meeting where we all get together. And then, so they're basically the consultants, the community consultants. They are expert consultants, and they tell us about, how people perceive things in the community, what messages would resonate, how we should frame our messaging and things like that. It's been really, really important input in designing all the advertising and dissemination materials. And they really have been great, just ambassadors about the study, just sharing information with people in the community, just talking to the neighbors and talking to people about what the study is. Hey, have you heard about that? You might want to check it out. It's really, it's really easy to participate and you get money. So they've been great. And also, opening doors and, hey, field staff, you can come set up a table here today. We can help you out, give you access to recruiting people. So for this messaging part, the advertising part, we use a social marketing approach, a framework that combines community-based research with social marketing, called community-based prevention marketing framework. And so we developed a campaign like as you develop a social marketing campaign, essentially who is our key audience or what are our sub audiences, what are the key messages that they care about, using the marketing principles like product placement, price, and promotion. I won't go into all those details, but going through that process of really, doing key informant interviews, talking in depth with the community advisory board about, and we have on our team, one of our faculty leads the Center for Appalachian Research at the university. She's a very big expert in Appalachian history and culture, and she was very crucial too as well in terms of how people perceive tobacco, how it's been part of the economy and culture for decades, and not as much anymore, but people have in many of the communities have a long established relationship with tobacco companies and sort of a love-hate relationship, if you want, with tobacco. So it's complicated basically. And then how we frame messages and things like that. So I wanted to give one example of some crucial feedback that they gave, that if we had just sat in our offices in Lexington to develop the materials, we would have really been off base in our marketing materials. And so this was our very talented graphic designer came up with this nice logo with mountains and a sun above it, and our apple trust at the bottom, and a couple other similar ones, but this one in particular, the comments were, those aren't our mountains. Those are not our mountains. And we were like, say more. What do you mean? I said, those are sharp peaks with snow caps. That's what the Rocky Mountains look like. That's not what Appalachian Mountains look like. We have rolling green hills. You saw that picture at the beginning of the thing. Rolling hills. We have rolling hills and they're green. They don't have snow and the rocks. So we're like, well, I mean, we knew that, but we didn't think about it. It was like, well, mountains are mountains, right? So if we had come this, and then and the sun looks like a beach sunset. So no, it basically tore it apart. So we're like, okay, wow, back to the drawing board. So what should it look like? And so we kind of went through a couple iterations, and that's how we came up with this beautiful logo that they loved. And they gave input along the way, and they voted for which ones they liked and why, and went through this process. And so, and when the field staff go out, they talk about all the time about how they get great feedback about, oh, I love your logo. It's so beautiful. Oh, and it's just really helped to give brand recognition and, feel familiar and friendly in the community. So that's just, I think, a great example of how the community input makes such a crucial difference. This is some shots from we have an annual meeting where all the CAB members can come, and the researchers, trainees, all the research staff, and all come, the field staff, and all come together to kind of get updates, latest updates. And we had the researchers and staff and trainees ability to go visit some of the local community organizations that we partner with, in these communities. It's like 2 or 3 hours from our house, so they don't go there very often. So that's really great. And then during the meeting, it was very interactive, where we had interactive tables for each of the projects to kind of get a sampling of what each project is doing, and experience some of those things and give feedback and ideas. So that's just some of the sampling. I was going to play our commercial, but the sound doesn't work, but you can see a little bit of it. Some of the messages that you'll see here, like Appalachians can have a say in the decisions. It said, did you know the FDA, makes decisions about how tobacco products are sold? Now Appalachians can have a say in those decisions. Because that was one of the key things that came out of the interviews and the CAB, and also our Appalachian expert, that, like I said, Appalachians were never in the data. All the data that's been informing FDA policies has been about urban areas and a few rural areas in the Midwest. And so this area where there's tons of tobacco use has not been part of that, where tobacco use patterns may be different. And so that has resonated with people, that they often feel like Appalachia's overlooked. People ignore us. Nobody cares about us over here, everybody's just looking at the big cities. So that message has resonated with people, like having a voice, having a say. Sorry again. And then emphasize, the money. We can't overemphasize that, right, with IRB, but making sure that's early in the message. All you have to do is take a survey. It's not an intervention. Other key things were, that there are tons and tons of tobacco cessation and prevention efforts out in the community, and studies from UK coming all the time. And so people who don't want to quit smoking will just turn off if they see it's about tobacco. Oh, I'm not even going to talk to you. I don't want to quit smoking. So they helped us in framing that and just saying we want people who use tobacco products and people who don't use the products. We're not going to ask you to quit using anything. Those are in the flyers because they thought it was really crucial, and it's been helpful. They've been able to recruit people, regardless of tobacco use. So just a couple of snapshots of the flyers. I want to make sure we have time to talk. So we have some young adult tailored flyers as well. So these are the general and the young adult. So they started the field staff, the first sort of like 9 months or so was just going out, like hitting the ground, hitting the pavement, in events and parking lots, recruiting people in person with the flyers and palm cards and things. And we've added, where you see asterisk, we have unique QR codes with each of the links, if it's electronic link, then it's a clickable link, but they have tags on them so we can see which flyer, which material it came from, and we can track the website hits that come from each one. Those are some of we have internet ads that, come up on the side of your panel while you're looking at things, when you're shopping, and then all of a sudden you see shoes come up in your advertisement. That way. We've experimented some with billboards and gas pump ads even. Those weren't very productive, so we stopped that. But the broadcast and streaming TV have been huge in getting awareness out in the community. And we're working with a marketing company that covers that whole Appalachian area, both of these areas, and Lexington as well. And they know what works, and they've really been great in helping us get a mixture of these general ads, like the TV and streaming TV ads, as well as these targeted ads, the internet ones that can target to people in age range, people who use tobacco, et cetera. And this is some snapshots of our field staff out in the community. They're almost done recruiting the non-probability sample. And then this is just some highlights of the website hits since July 2024, over 27,000 website views. And the first block at the top is people just typing in the URL. So over 10,000 is that. So if someone sees a flyer, sees the ad, and they go and type it in, or they go to a search engine and search for Apple Trust and then get to the website. So that's that first block there. And then the bottom one is all the various materials that had the link from the general flyer. So the printed flyer obviously was the biggest one because we've been using that a lot. And then later we added the targeted ads in March 2025 and have had a big hit with those. We don't have it on all the time, but the months that we have them on, we get a lot of hits from there. And then the probability sample, the random household sample, they started that late last year. So later into the process. And these are some of the materials that are specifically for those households. They get a postcard first, and they get a letter. Then they get then they come visit in person. They try to call if they can get a phone number. They leave a door hanger. And we just made a new ad that's going to come out. It's going to actually show the field staff and say, look in your mailbox for a letter from us. Your household might be chosen. And this is, then they go out and make in-person visits to the house to try to recruit people. So they've been learning about all the Google Map errors in Appalachia. So a lot of adventures, and when we had some flooding, and we've had different things. So they've had to deal with all of that those environmental challenges. And not going to go over our numbers up, but just we're about almost done with the non-probability sample. This was last month, 97% there. So we're almost done with a non-probability sample, and they're putting more of their concentration on the probability sample now. They're about a quarter of the way there already. And everything's on track for our timelines and making great progress. And they've had really great retention, 85% retention rates across every 6 months doing the waves. And we think it's because of that personal relationship that they form with the staff, as to when they sign up and they call them, they make they make monthly calls, text messages or calls. They're constantly in communication with them and building relationships. And they know them by name, and then the probability sample, we also do some additional things. So like if they don't have their own device or internet, they can use some study devices, and they only make visits to the home for the probability samples. So we have those accommodations for the probability sample. So in conclusion, I just wanted to say that these are kind of very different projects and very different things that we were co-designing, but I hope you've seen that has helped us yield very fruitful outcomes, and I think making the intervention better than it would have been, and making the community reception and support for this cohort study a lot wider known and more, greater awareness and support of it than we would have had just trying to do traditional approaches. And I want to give a shout out to our teams. And finally, one quote I like a lot is the founding director of our cancer center said, if the problem lies in the community, the solution lies in the community. And so that's why we always think we really, really value doing community engagement for all of our research whenever possible. Thank you. Those are our rolling hills.
All right, thank you. I'm going to start the questions with a virtual question. Clement Wilcox asks, this is for the first part of your seminar. Do you have a cost per patient for using the app?
Right now, there's not a cost. I mean, we've been used the grant money to pay the development cost. So, I mean, I think they will be moving forward. There's the original development cost that you put in, but then once it's done and we're ready to expand more to more patients, then we'll be able to see sort of a sustainability cost. Our plan is not to charge for it for now. We want to be able to make it broadly available. But I think mainly it would be what we've heard from the stakeholders is that it's having the staff time, the workflow figured out, and the staff assignments, the staff time to spend some time giving it to the patient, explain them how to use it and things like that.
All right, are there other questions? Hang on.
So could you share your reflections on having 2 community advisory boards, and if you had one, how that would have differed, like what you learned? And
yeah, it's a great question. Actually, so the first 2 years so we had separate meetings, and we actually found that it was not wildly different what we were discussing in each one. And so we got feedback from the CAB and decided to start having them together. So starting in January, we've been having both CABs meet together in the virtual meetings. And then our in-person meetings were alternating between the 2 communities. So like last year it was in the peri-urban area. Everybody's invited and we'll pay for their mileage if they want to drive over, but nobody came from the rural area. But same for the other, we're having in Hazard later this year, and we're going to try to encourage them to also come. But we're going to see if we can have at least some of it be on Zoom so they can join at least virtually. But yeah, it's been, I mean, different unique things come up, but it's also worked well to have them be together.
that's reassuring, because I was like, oh no, we have to have 2. I don't want to do 2.
From the first project with the app, have you found that the uptake from the clinicians is also high, or are there some that are more willing to implement it into practice?
Good question. We haven't gotten to the point where it's given to them so we're only doing it with enrolled study participants right now, and our staff is giving it to them right now. But we've been talking with the clinicians, and one of them is on our clinical collaborator meeting committee, and talking with others as well. And most of them were very enthusiastic about it, think it's really needed. And some of it is also learning more about, what does psych oncology services actually do? So it's also a learning moment of, yes, they do social needs. They don't just do emotional needs. But yeah, they're very supportive. Mm-hmm.
This was great. It was really nice to see 2 different projects. I have also a question about the first project. And as you're thinking about moving it from research into more of a sustainable program, what are some of the things that you're thinking about? I know that, like, more broadly, we're always thinking about challenges with reimbursement and how do you keep these people staffed, especially when they're focusing on more non-medical needs. And so what are the questions you're thinking about, and how are you kind of approaching that?
Yeah, I think the big 2 sustainability things are the EHR integration, interoperability, I think is the official word, and and sustainability in terms of staff. So, and that's one of the things the Alliance, all the grantees, we talk about a lot in our grantee meetings, and they provide have people come speak, because there are some new reimbursement opportunities. There's, you may be familiar, but principal illness navigation PIN codes that CMS came out with for Medicare, but it's a little complicated to use it. So UK Healthcare is not using it yet. And a lot of the sites a lot of places are not using it yet. Some of the grantees are using it, and we're all trying to learn from them and pass along information. And there's just some intricacies, because until other commercial providers also will reimburse for it, they feel uncomfortable or, hesitant about doing something that only Medicare is paying for. What do we do about everybody else? And then it requires a copay, which seems counterintuitive. That someone who needs $20 to pay for the gas, and you want to charge $20 for a copay, or so kind of working that out, and what do you do for people who can't pay, and what if they are uninsured, and I mean, so all the intricacies of that. So that's one of the things we're trying to get leadership together, having some meetings of like, how can we move this forward? What are the barriers? What can we do? So yeah, that's one of them. And there are some other ones as well of chronic disease management type of things. But those are, all of UK healthcare clinics are run as hospital-based clinics. And so we're not eligible to use those codes, which is something I didn't know before. So we're not using those, and we're not using PIN. So we're not doing any reimbursement right now. We're still just, Marquee is paying for it. Mm-hmm.
All right, great. We've run out of time today. Let's say thank you one more time to Dr. Hall.
Thank you.